This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, she's an elderly lady, that 85 years old, and she has got this black cataract. The problem is she also has pseudoexfoliation and a non-dilating pupil. So in this case, I consciously decided to do a manual small incision cataract surgery owing to the density of the nucleus. At this point, I'm not sure about the health of zonules, so I just wanted to play safe, and the surgery is being done under peribulbar anesthesia. The flap is raised. The epithelial tissue is scraped off. Minimal cautery is used to cauterize the bleeders. About 3 mm behind the limbus, I make a small groove measuring about 3 mm in width. This is just used as a fixation groove. And now the main incision groove is made, which is about 1.5 mm posterior to the limbus. And because I'm dealing with a very bulky and hard cataract, my incision is longer. It's about 7 mm. I begin my sclerocorneal tunnel by entering the center of the incision with a crescent blade. The wriggling motion gets me into the cornea. I'd go in up to 1.5 mm into the cornea, and then the sclerocorneal tunnel is extended laterally on either side. In this case, I've decided to use iris hooks for pupillary dilatation. So I'm going to make the paracentus incisions for the iris hooks. I'm making a second paracentus on the right side. This is for the iris hook. The first one I would be using it for maybe a cystitome or for introducing the cannulas. The paracentesis incision for the iris hooks are much more shorter and much more posterior to the limbus. So one I made it at 6 o'clock, and the fourth one is made just beside the primary scleral incision. The iris hooks are now introduced into the antechamber. The main incision is now entered with a sharp keratome. We ensure that the inner lip looks like a smile incision, whereas the external incision will be like a frown incision. Time to insert all the remaining iris hooks. So initially we would not want to stretch the pupil a lot, just engage it and stretch it a bit. And finally, when the last hook is placed, then we stretch it. Now, I want to restain the capsule here. Again, try to put in air bubble and restain it, because once the viscoelastic has touched the capsule, the staining would not be great. But still, doing this exercise is very helpful, especially in these black cataracts where visualization is challenging. As I try to puncture the capsule, we can see these radiating folds arising from the puncture site, suggesting that the zonular health is not great. The capsule is pinched with the forceps, and then a flap is raised, and eventually a rhexis is performed. I'm conscious that the rhexis has to be minimum of 6 mm. I don't intend to have a smaller rhexis because prolapsing the nucleus out of the bag is going to be a challenge if we make a very small rhexis. Gentle iodissection ensures that the corticocapsular adhesions are broken. Viscoelastic is placed into the eye. Now is the time to maneuver the nucleus out of the bag. So as I keep telling that, the bimanual way of maneuvering the nucleus out of the bag is very helpful in such situations where we're dealing with a very large nucleus and probably associated with zonular weakness. Let me just slow down the movements which I do here for the benefit of the beginners. The two synskukes are introduced into the eye. The synskuk from the right hand pushes the nucleus to the right side so that the equator on the left side is exposed. The synskuk in my left hand goes under the nucleus, and then it lifts up and rotates the nucleus towards the left side. With one synskuk being below, the other synskuk engages the equator of the nucleus, and the nucleus is now pushed upwards and to the left side. And by doing so for a few seconds, the nucleus eventually gets itself wheeled out of the bag. Now we have an entire large bulky nucleus sitting into the antechamber. So this bimanual way of weeding the nucleus out is a very elegant way of maneuvering the nucleus out of the bag, and it comes in really handy in these manual small incision cataract surgeries. So now is the time to extract the nucleus out. I'm going to use the phaco sandwich technique, and for the benefit of the beginners, I'm going to demonstrate a few principles here. So the nucleus is suspended in a bolus of OVD both in front and behind. The dialer enters in first, followed by the vectus. When the vectus is being introduced, it actually dips down under the nucleus, follows the curvature of the nucleus, and then goes behind. Important point to note here is that even in such a dark black nucleus, we can still visualize the vectus under it. We should be mindful at this point that the vectus is not engaging iris or any other structure. So it's important that we don't push the vectus until the entire span of the nucleus. It has to stop at least about 75 to 80% of the diameter of the nucleus. On the contrary, the dialer we want it to be covering the entire span of the nucleus. The second point to observe here is that the dialer has to be exactly in center of the vectus underneath it. So if you have an oblong, or if both of them are not aligned properly, there is a risk of the lens tilting in the antechamber. So it's important that the vectus is holding the center of the nucleus and the dialer is placed exactly on the center of the nucleus. By this, we ensure that the nucleus does not tilt or torque. Now, the dialer presses the nucleus against the vectus, and this is what we call as a sandwich. The nucleus is sandwiched in between these two instruments, and now the entire complex of the lens, nucleus, and the dialer is pulled out of the bag. Now, since we have made an adequately large incision, the nucleus can be brought out effortlessly. The epinucleus in the cortex is then purged out using viscoelastic bolus. Small remaining cortical fibers are aspirated. During cortex aspiration, we need to be mindful that the bag is weak and there is always a chance of inducing a zonular dehiscence during this last step of the surgery. Before putting the IOL in the bag, I would like to place a CTR. Since I noted that the zonular health was not great, the CTR is threaded in through the side port, which I already have. Planned rigid PMMA lens is put into the bag. All the iris hooks are then removed. And we can see that there are a lot of sphincter tears, which is quite evident. But this is a price which we have to pay when we stretch the iris a lot. But in this case, trying to save the bag and having an uncomplicated surgery itself was a challenge, and this is a small price which we need to pay for it. The OVD both in front and behind the lens is aspirated out. To counter the large amount of against the rule astigmatism which might be induced because of this large incision, I am going to suture the main incision. Although it is self-sealing, the idea of using the suture is to minimize the surgically induced against the rule astigmatism. The conjunctival flap covers the wound and the two edges are cauterized. So this gives a good covering of the wound area, and that's it, the case is done. So to summarize, when we are dealing with such a tough case of a hard nucleus and a non-dilating pupil, iris hooks are very handy, especially when we are planning manual small incision cataract surgery. They are the ideal devices rather than the pupil-based devices, because in bulky nucleus, when you're trying to mobilize the nucleus out of the bag, there's every chance that we're going to dislodge the pupil-based devices. So that's the reason why iris hooks still remain the gold standard when you're trying to use them in manual small incision cataract surgery. So when dealing with these hard cataracts, one needs to be very liberal in choosing the size of rhexis and also the incision, because these are the two obstacles which can make the surgery very complicated. That was it. Thank you for watching and hope you found this helpful.